on the behalf of IAP Palghar district branch. Today we are gathered here for this Zoom meeting on the occasion of World Liver Day, which was there yesterday on 19th of April. And this day is celebrated worldwide regarding to increase the awareness of the liver diseases. So that's the first thing. And I'll just share the screen or banner. Okay. So I hope it is visible to everyone, the banner. Yeah. Um, to know, just in short, I'm just going to tell everyone, all of us are pediatricians know about the liver, but just to summarize regarding liver as an organ, it is the largest solid organ of the body, and all of us know the role, the most commonly important role of liver in the digestive system, in the metabolism of carbohydrate, fats, proteins, and lipids. Other than that, it's a role in regulating the blood clotting factors, as well as also removal of toxins from the body. So these are the most important function. And also for pediatrician point of view, in early infancy, it has a role in hemopoiesis, extra erythropoietic hemopoiesis. So these are the most important physiological functions of the liver. Other than that, as a pediatrician, in a day-to-day practice, our routine daily practice, the what liver diseases we what we liver diseases see is basically the routine common physiological neonatal jaundice, as well as neonatal cholestasis, biliary atresia. Other than that, in infants or elderly age group, liver infections, acute and chronic infections, viral infections, we see more commonly. Other than that, also liver damage or because of the drug induced liver damage that we see is mainly the anti-epileptic drugs and anti-tubercular drugs, which are commonly we see as a pediatrician. Other than that, liver abscesses, amoebic abscesses, pyemic abscesses, these are the common day-to-day practice pediatrician we see as far as liver is concerned. Other than that, also we see uncommonly liver diseases like Wilson's disease, portal hypertension, cystic diseases of biliary tract like colorectal cyst and so on. Also, rarely we come across hepatic in routine practice, hepatic failure patient, acute hepatic failure, chronic hepatic failure, or maybe cirrhosis of liver patients. And also, we heard of the liver transplantation in our as we are already practicing for 15-20 years, so we really don't know the details of it, but we heard of liver transplantation. And I'm very sure today we have Dr. Lalit Verma. He's a pediatric gastroenterologist, and we all of us know him in our group. He's a very familiar face with us as a pediatric gastroenterologist, and he has a lot of inputs every time in our CMEs as well as for the discussions regarding the cases. He's a pediatric gastroenterologist attached to SRCC hospital, and today he is going to talk on acute on chronic liver diseases. And yesterday only in our group we have seen the photographs of World Liver Day, which is basically celebrated by the gastroenterologist at SRCC hospital of the liver with the liver transplantation patient, and it was really encouraging for us and interesting for us. So I just welcome Dr. Lalit Verma, and I just asked him to go ahead with his talk regarding acute and chronic liver disease.
Sure. Thank you, Dr. Girish, for the introduction, and welcome you all. I said I might be late, but glad that I've made it on time. All right. So, the topic could be changed or be tossed upon acute on chronic or ABCs or interpretation of the LFTs. So there are some basic
Just
things.
a minute. I think Girish has to stop screen share. So Lalit.
Okay.
Oh, it has not been
Yeah,
shared.
Yeah. Yeah, I stopped sharing, madam.
Yeah, we can see Lalit's now.
Okay, now you can see that. So yeah, you can just toss around the topic ABCs of LFTs or acute on chronic, depending, and interpretations of LFTs. So I'm just going to go further on this. So we all know that once you do an LFTs, there can be a lot of ifs and buts if we don't do a complete LFT. What I mean here is sometimes even because we want to save the cost of the child, but then it doesn't help. The families sometimes are poor. But just doing SGOT, SGPT versus LFTs might save some, but will not get the complete answer. Why we need the complete LFTs is very important. So normal LFT does not ensure that the patient is free of liver disease. Example, it can be a compensated cirrhosis, so what happens in compensated cirrhosis over a period of time, the bilirubin will be high, but the SGOT, SGPT can start declining. And some of this chronic liver disease patients just have SGOT, SGPTs, which are in 70s or hundreds, and sometimes even towards the normal side. So we need to understand that normal LFT does not mean that everything is fine within the liver. Second, tests are not specific for a liver function. So there's no test which can tell you, oh, SGOT is high, it's viral, SGPT is high, it's XYZ thing. So it's not specific for any particular disease. Tests do not usually provide a specific etiology, but are indicative of any liver disorder. What I mean here is they will tell you, okay, there is something here, but we have to do more if the LFTs are deranged. Fourth is clinical significance of any abnormal LFT must be interpreted in each individual patient cases. So we often get patients with, say, viral disease, where the SGOTs are in thousands. But likewise, we can get a patient where the SGOT is 100 or 120 or 150, but that patient might require a liver transplant versus the one who has a very high SGOT, SGPT, but that can be dengue, that can be a viral, which can settle down over a period of time. So it's not, so it has to be individual case-based scenario. Second thing, of course, we need to know the time frame. Third, I'm just working up a patient who presented with Ankit and me here in Bukhar. First time, 10 days history of ascites and higher bilirubin. So I'll tell you more about it later as we go. But that does not mean that it's only for a short course. It might be there, but just missed. Second, we know that serum bilirubin, there is conjugated and unconjugated. Sometimes both can be high. So when we talk about unconjugated, of course, we know about conditions that are sickle cell, thalassemia, neonatal jaundice. Then there are only two conditions which actually involve the liver, which is Gilbert's, where the kid can present even in when there are teens, or it can be picked up a bit earlier also. But the significant ones are the Krigler-Najjar 1 and 2. Of course, they will need a transplant because although it is indirect hyperbilirubinemia, but it's a problem where the liver needs to be replaced by a better one for the enzymes. Number two, when you talk about conjugated and unconjugated both being high, which is called your biphasic, it can be there in drug-induced hepatitis, it can be in alcoholic hepatitis and viral hepatitis. When we only talk about conjugated, which is your direct positive, it is post-hepatic or obstructive. And then we can, of course, think about gallstones in our patient population, cholelithiasis, cholelitical cyst, biliary atresia, tumors of biliary tract, more common in adults, and carcinoma of head of pancreas. Anything that is obstructing the outflow of the bile. So this is from Canada. Actually, when I was training, we always said when the bilirubin exceeds more than 2 milligram, it diffuses in the tissue, it causes yellowish skin, sclera, and the urine becomes discolored. Conjugated bilirubin is water-soluble. Hence, if the urine is yellow, it is definitely a conjugated hyperbilirubinemia and not the unconjugated one. So the important thing to ask here is, urine yellow hai, then of course we think about conjugated hyperbilirubinemia. And here is that what we spoke about. Pre-hepatic is because of the overproduction or impaired uptake by the liver. The impaired uptake is, when of course, we talk about neonatal, small neonates also, premature neonates, they can have impaired uptake by the liver. Second is overproduction, like in sicklers. Third is, hepatic when there is decreased conjugation. And fourth, the last one that I spoke about is the obstructive, which can be because of gallbladder, cancer here, or cortical cyst here, and so on. So, of course, we did this. Unconjugated is albumin bound, so it is never present in the urine. Conjugated is direct reacting bilirubin. It will be seen in urine. Okay, things are clear, right? Now, tests that detect injury to the hepatocytes, of course, we know ALT, SGPT. So primary marker of the hepatocellular injury, it is the most sensitive, more specific than the AST. So ASTs can be elevated in which conditions apart from liver? Anybody? Please unmute anybody. It's fine because it has to be a two-way interaction only. Then it's more fun. Dr. Anjali is on there.
Cardiac, brain.
Yes, perfect. Cardiac, brain, and sometimes even the kidneys. So yeah. So no correlation. And here when we talk about ALT, there's no correlation with the extent of damage. So when we say, "Are 1,000 is kind of damage," it's not that. It's just that it has diffused, or the time we do the blood test, we pick the higher number, but that doesn't tell you exactly the extent of damage. Second, here when we have a very high ALT, which is like 15 to 20 times, definitely we need to talk about ischemia, which is much higher. It can be in cardiogenic shock, hypotension, CCF, but it comes down rapidly when there is ischemia. So whenever a cardiac surgery is done, they'll often call me, and of course we see enzymes like in thousands, but then we tell them post-spontaneous, okay, it's going to settle down, just give it some time. The second common condition is viral hepatitis, where the numbers are really very worried, sometimes worrisome when you have 5,000s also. 10,000 is, I think I saw it in Virar only 10,000. And the other one is autoimmune, where you'll definitely, so autoimmune can be again something which becomes very challenging. So it starts, showing up some symptoms when they are 4 or 5. Sometimes this autoimmune disease will present when they are like, in their 10 or 11 years of life. They'll just present as acute onset, and they'll be very sick with a lot of ascites, and the numbers of SGOT, SGPT will be very high. Then we talk about drug toxicity, basically of paracetamol, and severe toxic hepatitis. When you talk about severe toxic hepatitis, I think Dr. Girish pointed out some toxins. Can we know of some toxins which really is culprit here? Anybody knows of any food or chemicals?
Copper.
Copper.
Sorry.
He said copper.
Copper, copper. Copper is one. Yeah, copper will cause, but it's a slow toxin. The rapid toxin that we talk about is mushroom. So some mushrooms are wild, and they are pretty dangerous. There have been deaths. The second one is the rat poison. Of course, and the phosphorus contains phosphorus and some chemical solvents from the industry. So this three will definitely have very elevated enzymes. Then the other one is acute Budd-Chiari syndrome, where the ALT is very high. So I've divided into high and moderate ALT. So we just spoke about very severe raise in the ALT. Now we talk about moderate elevation of ALT, which is 5 to 15 times. There we spoke about 15 to 20 times. It's no particular order, but it can just overcross each other. So basically moderate ALT rises in any chronic hepatitis. So now we know that, as I said, the numbers can just be like, if 50 is the normal, it can just be 200 or 250, where actually it is chronic hepatitis. Something is going on with the liver for quite some time. The second is the cholestasis with definitely the GGT is going to be high. That's the reason we need not just SGOT, SGPT, but also your GGT and alphas. Cardiac, of course, will cause severe hepatic congestion in cardiac failure like CCF. It can present as severe or moderate. Other ones are muscle injury and kidney injuries, which can also cause moderate elevation in the ALT. And when we talk about mild increase, which is less than 5 times, so if the normal value is 50, we're just talking about less than 250, is seen as neonatal hepatitis of many origins. We'll talk about it. Hemochromatosis, NASH, which is non-alcoholic steatohepatitis, biliary atresia, alpha-1. So most of the condition which actually require liver transplant is here in mild increase only. So that's what we need to know, that thousands, so itna worrisome nahi hai, but that 250 is the worrisome thing. So alpha-1 antitrypsin deficiency, Wilson's, autoimmune hepatitis, infections like mononucleosis, CMV, EBV, drugs apart from that paracetamol. Also, when we talk about ATT, so a lot of times we face that the kid is on anti-tubercular drugs, but we have to change to second line because there is elevation of the enzymes. So of course, anti-tubercular drugs, anti-epileptic drugs like sodium valproate, antibiotics, including all the antibiotics. It can be augmentin, azithro, anything. PCM therapeutic doses also collectively can cause this. Of course, there we are talking about the toxic dose when there is poisoning, but here we're talking about therapeutic dose. False low ALT is seen in dialysis, pyridoxine deficiency. Any questions so far?
No, sir.
So we'll switch to AST and SGOT now. So that was ALT. So in when we talk about SGOT, as Dr. Anjali also gave her inputs, it can be liver, cardiac, skeletal muscle, kidneys, brain. I've never came across, but literature is there, and pancreas. Reflex damage to the hepatic cell, but less specific for the liver disease. So of course, SGPT is very specific to liver. SGOT is not so much. But of course, when we talk about very high AST, which is more than 20 times, it can again be seen in ischemic liver injury, shock and hypoperfusion, viral hepatitis, and drug-induced hepatic injury. When we talk about moderate elevation of SGOT, which is your AST, is seen in cardiac conditions, cardiac failure, infections like subtle viral infections, and alcoholic cirrhosis. So, अगर किसी को पकड़ना है, whether they take alcohol and that's too much, there are two things. One is your AST. What is the other one?
USG.
From the liver enzymes.
Oh, okay. Alkaline phosphatase.
Chalo, we'll keep it. Anybody else?
Which liver?
That was close.
Then GGT.
Yes, GGT. It's coming. So mild elevation of AST is again seen in any chronic hepatitis condition in adults, of course, specifically alcoholic fatty liver. Metastatic hepatic tumors can also cause this. When we talk about muscle problems with elevated SG, OT is in dermatomyositis, calf muscle myositis. Even hemolytic anemias can give a rise to your SGOT, and drugs, almost any drugs which we spoke about can cause this. Mitunda, I think you're yeah, unmute.
In HI also, HI also, na?
Yes,
Hypoxic.
Yes,
Yeah.
it will be elevated. Yes, you're right. Now, we talk about ratios, and more or less, it is correlated, but not always. So when we talk about it, let's see, ratios between AST and ALT are useful in differentials. So when there is equal rise, when your AST is equal to your AST, it's ischemia. It can be a shock, it can be hypoxic condition, or it can be hypoperfusion injury to the liver. When we talk about AST and ALT ratio less than 1, which means there is more ALT specific for any hepatocellular damage. It can be seen in PCM poisoning, hepatocellular with the necrosis of hepatocytes. The second are the viral hepatitis, when the ALT is very high compared to your AST. Toxic hepatitis that we spoke about, toxins like mushroom, or phosphorus and rat poison, and cholestatic hepatitis. Number 3, in chronic active hepatitis, when it is active, then of course your ALT is much higher than your AST and NASH. When your AST is more than your ALT now. So here we talk about any chronic liver disease, cirrhosis, Wilson's disease. So remember that Wilson's will present with this scenario where your AST is higher than your ALT. Bile duct obstructions and tumors. And why depletion of vitamin B6 in chronic alcoholic causes this? Because ALT and AST both use B6 as a coenzyme, but the synthesis of ALT is more strongly inhibited when there is a pyridoxine deficiency than is the synthesis of AST. So the reason the ALT is much lower is because in pyridoxine in alcoholics is because of this. Now let's switch to ALPHOS, alkaline phosphatase. We don't give it much importance, but there are certain conditions where we really need to have your ALPHOS also. So the source again for alkaline phosphatase is your liver, bones, kidney, placenta, and intestine. Serum level of ALP varies considerably with the age. So normal growing children, remember that, and rapidly growing adolescents in particular have higher serum ALP, which is mostly of bone origin, coinciding with the periods of maximum growth velocity. So we need to keep this in mind. In case with high ALP, the best indicator of hepatobiliary disease is concomitant elevation of your GGT, because they are due to obstruction. So when your GGT and ALPHOS both are elevated, then you should think about liver. When it is an isolated ALPHOS, very rarely it is a purely liver disease, then you need to think about something else like bones also. Isolated increase of ALP does not indicate liver or biliary disease if other liver tests are normal. The differential diagnosis of increased serum ALP in the absence of liver disease includes, again, pregnancy, familial inheritance, certain family members have higher ALPs, chronic liver failures, blood group B or O, and transient hyperphosphatemia in infancy. So these are the conditions that you have automatically elevated ALP. Now, increased ALP pertaining to your liver. So results of increased synthesis of enzymes by the cells lining the bile canal in response to cholestasis. So most of the time, the rise in the ALP is because of that cholestasis. It can be an intrahepatic cholestasis or extrahepatic cholestasis, even before a rise is seen in the bilirubin. So bilirubin actually is the last one to rise. When we talk about liver, think about marked rise is seen in EHBA, which is your extrahepatic biliary atresia. Viral hepatitis. When we talk about renal condition, it's renal failure. CVS heart failure, it is mildly elevated. Infections like mononucleosis and fungal infection can cause a marked rise. Bones, you see higher values in bone metastasis, Paget disease, osteomalacia, rickets, and hyperparathyroidism. And then, of course, we know about placenta. From placenta into the late pregnancy, it is physiological increase in your ALP. So when you talk about liver, it is mostly obstructive and sometimes viral. Obstructive may basically, when you're talking about an infant, it is biliary atresia. Now, we also see low LP, and the one in red is significant because in Wilson's disease, you have low LP. And the lower the LP, the prognosis really becomes poor. It's coming in further discussion, but you can see low LP in malnutrition, zinc deficiency, vitamin C deficiency, hypothyroidism, pernicious anemia, and congenital hypophosphatasia. So another ratio which is very important, low LP by the bilirubin ratio. In fulminant Wilson's disease, regardless of the cause of acute hepatic failure, a low LP over bilirubin ratio is associated with poor prognosis. So this is very important. If your bilirubin is super high and ALP is low, then it is fulminant Wilson's disease. And we had one patient that we did the transplant, lucky one, but I didn't get much time to put in here details, but he actually presented like a fulminant hepatic failure. In the setting of Wilson's disease, we had to work up this child within 2 days and get him for the transplant. And he was lucky because there was no family match, and we listed him on the cadaver list, and he got a donor. Switching to GGT, so source is again liver, renal tubules, brain, pancreas, and intestinal cells. In normal full-term units, serum GGT activity is 6 to 7 times the upper limit, that of an adult range. Slowly it starts to decline, and by 6 to 7 months, it comes back to normal. GGT is most sensitive, more than ALT, for detecting hepatobiliary damage, but use limited by lack of specificity. So it's not very specific, but it is definitely most sensitive. Particularly sensitive in alcoholic liver disease. So now you know, somebody is lying, send two things, GGT and SGOT. Increased levels of serum GGT is seen in response to any hepatobiliary injury. In biliary atresia, there is a marked elevation. Any other causes of obstructive jaundice? Anyone wants to pitch it? In a pediatric population. Throw in anything.
Biliary atresia.
Is one. Probably we have also diagnosed one.
A choledochal cyst.
Perfect. That is what I wanted to hear. Choledochal cyst, and sometimes even the choledocholithiasis, a big size stone, can also do this because it will block your duct and even the ampulla, and sometimes we see a very high levels of GGT. In acute viral hepatitis, so in viral hepatitis, when you pick them up very early, it will be low. It starts picking up in 2nd or 3rd week, may remain for 6 weeks, then again it starts getting better and declining. Other causes, as I said, non-specific ones are pancreatitis, brain tumors, and renal. So GGT uses, it confers liver specificity to elevated alkaline phosphatase. So as we said, if only your ALP, alkaline phosphatase, is high, it does not have any meaning. But if your GGT is elevated, then you should definitely think of cholestasis. Any significance in PFIX?
In
PFIC. progressive familial intrahepatic cholestasis. If not, we'll come to it. In aminotransferase level elevation with AST to ALT ratio more than 2, elevation of GGT further supports alcoholic liver disease. Note that an isolated elevation of GGT does not need to be further evaluated unless there are additional clinical risk factors for the liver disease. Common bile duct stones can simulate acute hepatitis, AST and ALT becomes elevated immediately, but elevation of alkaline phosphatase and GGT is delayed. So any CVD stone can present like an acute hepatitis only. Definitely we should do a sonography to rule out that stone. And preferably even if your amylase and lipase is elevated, then also think about adding an MRI, MRCP, because that stone can be at the junction of the CVD and the pancreatic duct or at the ampulla. LDH, we don't, I mean, we do it post-transplant just to see, but basically it is an isoenzyme for heart, kidneys, lungs, liver, and skeletal muscle. When we talk about hepatobiliary, then of course we see an elevation in hepatitis, active cirrhosis, and hepatic congestion. Three things that LDH is elevated. So of course, since we have the background, let's switch to a case now. And this case, I'm going to just change a bit and we'll keep questioning each other because that is how we'll make it interesting. It can be the similar scenario in a younger child, but let's take this child first. So AK is a 16-month-old male who was completely asymptomatic for 6 months of life. Incidence onset of itching, which started actually in the upper body at 7 months of life. They thought it's eczema and started treating with the skin specialist. By age 9 months, had persistent general itching. By 11 months of age, he developed jaundice. Before presenting, he was seen by multiple dermatologists because they actually thought it's eczema. Any thoughts here? Is it really liver or something more or no? Just that.
Yeah, with the development
Jaundice.
yeah.
Jaundice is there, definitely some obstruction is there. So we should think of liver pathology.
Yes. Anybody else? Okay, fine.
No,
So you're right. But if you take down that 11 months, by 9 months, he only had eczema and generalized itching. So, and I just saw, I'll talk about the other one that I saw yesterday. I am working up. Similar thing, 2 years and no other symptoms till now, but started having symptoms. So, yeah, somehow. I think some of the things are here and there. So anyways, I'll tell you here. Can I just open my email if you don't mind?
Yeah, sure.
Because the IT guy was running late, so I asked him to download it, but it's not.
I doubt any of us would have thought of a liver disease at 7 months with just itching. So that's such a strong take-home point that when there is a child with itching, think beyond eczema.
I'll just try and open the other one so that will make it interesting.
Differential diagnosis of generalized itching in an infant. We should discuss.
Yes.
Scabies.
Even scabies is so actually only generalized scabies.
Yeah, yes.
Yeah, dry skin.
Okay, I found it, but give me some time to open it.
Atopic dermatitis kind.
Yeah, that he said was treated for eczema, atopic dermatitis.
Yes.
Okay, I got it here. I just need to download it. Otherwise, it won't make it interesting.
Yeah, please go ahead.
Are you able to see my screen now?
We are seeing your previous case scenario history of illness.
Enable editing. Just 2 minutes. Save as. Desktop. LFT PPT. Okay. So I'm done here. I'll just stop share this. So not seen anymore, not that one. Let me try and see if this is. You can see it now.
We can't see your
No.
Lalit. We can see
Okay.
your
Okay.
left.
Okay. Okay. Fine. Got it. Just one moment. Okay. You can't see my screen now?
Yeah. Above
Symptom.
associated with that one.
Above symptoms, yeah. You can
Yes.
see that?
Yes. Yeah, we
Okay.
can see that.
Okay, I'll make it now clear. Okay.
Yeah.
Thank you. So, above symptoms were associated with bloating, decreased appetite, and a weight loss. Due to severe itching, had inability to sleep at night. Bowel movements were 1 to 3 per day, and 50% of these stools had become acolic. Family history, non-contributory, nobody had any liver disease, but social history, 3rd degree consanguineous marriage. Any thoughts here? Acolic stools now.
So definitely going for obstruction.
Yeah, perfect.
Yeah.
Now, weight when I saw this child was around 6.9. For this, of course, he was less than 3rd. Height 58, less than 3rd. Very irritable child. No facial anomaly. Scleral icterus was there. Sparse hair. Which are the conditions where we see facial anomaly when we're talking about liver? Anybody?
Allergy.
Perfect. Clear to auscultation bilaterally. No murmur. Again, which condition do we have murmur? There are 2. You have seen this case. Huh?
Congenital rubella.
Okay. Yeah, rubella, you have. Yeah. So, again, your allergy, you have PPS, peripheral pulmonic stenosis. And sometimes we have to actually correct that before we take the child for the liver transplant. The second one are the biliary atresia with splenic malformation. So that is called BASM. It's a constellation of syndromes actually where there is cardiac problem, there is spleen form problem, and there is also biliary atresia. It occurs in less than 5% of the total biliary atresia base.
What is it
In this
called?
case, BASM, biliary atresia splenic malformation.
Okay.
Abdomen in this child was very tense, distended. There was minimal ascites, hepatomegaly 2 to 3 centimeters below right coastal margin, and there was definitely a caput medusa. Skin was jaundiced, a lot of scratch marks, pigmentation with a lot of itching. So these are the pertinent labs. When these kids really come, we just send the basic ones and see where we are at. So hemoglobin 9.2, platelets were 569, and white count was borderline high. SGOD, if you see, was 155, SGPD of 234, ALK was 448, bilirubin total 4.8, of which direct was 4.1. Proteins 6, albumin of 3.5, GGT of 30, which was low, and serum bile acids were high at 147. INR 1.4, borderline high, and slightly deranged PTT. So just based on this, which direction will we go? What do you think should be the next step?
Go along the yellow line.
And that should be doing further investigation. But then again, they are so, this child I remember is from Bandra, very non-affording. They stay in a chawl. So I'll tell you what we did next. So then we had to do other tests. Serum glucose 90. So all these tests are pertinent to liver. Please, we'll discuss each one of this. Serum glucose was 90. Plasma ammonia was 75. plasma amino acids were normal, pH was normal, urine organic acids negative, succinyl acetone negative, stool fats negative, stool for reducing substance negative, urine and blood culture negative. I do this for all the kids because sometimes it can be urine infection or blood infection, which can present with jaundice. CMV, DNA, PCR. Again, it's very important that you get a quantitative, not the qualitative. If there's simple things like a baby is born and if you see a deranged enzyme, always send CMV, DNA, PCR quantitative. And of course, thyroid is very important. Next is the other slides will have why those tests are relevant. On imaging, we found enlarged liver that was also there on the exam 11.5, no focal lesion, no intrahepatic biliary radicals dilation, normal in echogenicity, normal PV and CVD, GB collapsed though, spleen 8 centimeters, mild enlarged, kidneys were normal, chest X-ray was normal. I always get a 2D echo done. Sometimes we miss few things. So there was no PPS and normal ophthalmic exam. Now, when do we have problems with the ophthalmology? When it is correlating with your liver. Two conditions where we know that opthal check is a must.
Wilson.
Wilson.
Wilson's KF ring. Yes. And which is the other one?
Galactosemia with.
Oh, then it should be 3. Perfect, madam. You just hit it on the infection. Other third one?
HIV.
Okay. Okay. Fourth one now.
Ataxia telangiectasia.
Ataxia telangiectasia. नहीं क्या बोले कोई?
He said ataxia telangiectasia.
Okay. The important one, which actually is purely liver related, is your allergies only. It has posterior embryotoxin. So again, an opthal check is a must in this kids also. And opthal has become so important because out of the 12 patients we did a transplant, 4 were Wilson's and 2 with a KF ring. And we barely get any time because they always present with acute on chronic lack of picture. Severe ascites, 2 of them in the PICU. We had to pull them out of the PICU first from the ICU to take them for the transplant. So 2 things that we always did is to check ceruloplasmin. If it is less than 5, it is definitely Wilson's. Second, which will give you instant answer, is your KF ring. So again, it can be there in other condition, but yes, when you have a liver problem with jaundice and everything, then definitely KF ring, because you know that 24-hour urine copper takes time. If I do a biopsy, it's going to take some time. So immediate answer is given at least by 2 of this. So differential here, why I did those tests will be here. So let's start knowing. Okay, did we miss a biliary atresia? What do we think?
Yes, could be.
Okay, perfect. So it can present late because you know most of the times this biliary atresia patients, by the time they present, when they come from interiors, nobody tells them that you know they have to go and get a Kasai gun. It can be missed. But by the time they are 8 or 9 months, they go downhill. Yeah, there is significant failure to thrive, significant ascites, and probably they will not be able to make their first birthday if there is no transplant done. So this child had normal echogenicity plus GB was clearly seen. So we don't think. Why is your tyrosinemia?
Your USG said absent gallbladder.
No, it must have said present. No, it was there. I must have changed the scenario, but it was there.
Okay.
So,
okay.
Yeah, so it was there. So in this patient, the GB was in. That talk I give actually for the GPs, but I had to change because they will not understand other things. So this why not tyrosinemia? Because we had a normal urine succinyl acetone. Again, it gives you a very quick answer within the same day, and normal plasma tyrosine levels. Why not a urea cycle defect and amino acid defect? Anyone?
Sugar was normal.
What was normal?
The sugar, blood sugar.
No, blood sugar was normal and ammonia was normal. In urea cycle defect, definitely will, because related to the ammonia. Ammonia is definitely high. When do these kids with urea cycle present? My first transplant was a urea cycle defect baby, where we did the transplant at 2 years. Now he's 7 years and doing all fine from the ISL. So they will always present. The first 4 to 5 months are pretty okay, most of the times, but one of these odd ones will have some problem beginning second month. They're very chubby babies initially, but then they go downhill. When it is too late, then what happens? Even the skills that they had, the motor skills that they get, will be reversed. So we have to take them for a transplant for the same reason, unless they are put on small normal diet, like low protein diet. So normal plasma ammonia in our patient and plasma amino acids were normal. So alpha 1 antitrypsin nahi hai because we did an A180 levels which are normal. Bile acid synthesis defect nahi hai because our bile acid was elevated. In bile acid synthesis defect, which is an upcoming thing, we have been picking up more cases day by day. It is again a genetic condition. So in this condition, the bile acid is low, but in our patient it was 127, which was high. Allergies kyun nahi hai? Because we had a normal chest X-ray, we had normal 2D echo, we had normal ophthal exam. Chest X-ray or X significance. What do we see in the spine in allergies? Hemivertebral. Okay. So more differential. Ma'am, you said glucose. So galactosemia may it becomes important because they definitely will have a low sugar value. But in our child, the glucose was normal reducing substance, and the GALT enzyme was normal. Fructosemia usually starts presenting after 6 months when you start introducing sucrose and fruits in their diet or syrups in their diet. Again, they will have a hypoglycemic spell. They will have a positive urine reducing substance and normal enzyme in our patients. So basically, fructosemia is out because we had a child with a normal blood glucose level, number one, negative urine reducing substance, and normal enzyme. Why is our child not having fatty acid oxidation defect? Because we have a normal glucose. Again, why is pH important? Because of fatty acid oxidation defect, there will be acidotic, and we have a normal acylcarnitine levels. Organic acids may be pH will be acidic, which was not there in our child. There was no lethargy. They present with lethargy, and again we have a child which has normal ammonia. So organic acid is also out. Can it be drug induced? There is no relevant history. But I have found 2 or 3 patients when we don't do a level, especially when they're on valproate, then there can be delay, which is called drug-induced liver injury. If Samir is around, then he might remember one of the child that we had in Wokhard presented with delay. Luckily, we sent the levels of sodium valproate, and we figured out it is drug-induced, and we stopped the drug and called the neurologist. Can it be idiopathic infectious viral? Yes, it can be, but a possible condition was urine CMV, but we have a negative value. So now what are we dealing with? इतना सब कुछ कर लिया, लीवर में ऐसी है, काफी बार कुछ भी नहीं मिलता है. Where do we head next? Next is your sending a whole genome. And we did a liver biopsy. So hepatocytes, intrahepatic canalculia were present. This case was diagnosed as PFIC type 2, where you have giant cells with a lot of neutrophils and lymphocytes here. And there is periportal inflammation that you see here. Some areas will have a paucity of bile ducts. That is very typical of PFIC type 2 and also allergies. So if you, this is a small study from India only. If you see N is equal to 37, of course, biliary atresia is there as green. You have idiopathic cases where we don't find anything, whatever workup you do. Preterm birth will have deranged LFTs. PFICs are coming up. So a lot of these PFICs actually were placed in the biliary atresia group. When we did not have much knowledge about PFICs, most of this PFIC ended up as biliary atresia patient. Then we have allergies, some biliary sludge, alpha-1 antitrypsin defect. We have cystic fibrosis, which we have Gaucher's, and neonatal diarrhea can also cause this. So what we know about PFIC that this child has, so there is not just 1, 2, or 3, but 3 more have been added up till 6. Now we have PFIC 1, 2, 3, 4, 5, 6. It is inherited as autosomal recessive and presents as hepatocellular cholestasis. There is some problem in the...
Lalit, tell us the full form of PFIC, okay?
Okay. Progressive familial intrahepatic cholestasis. Got it? Yeah. Progressive familial intrahepatic cholestasis. That does not mean that it's only runs in the families. But of course, this child had a consanguineous marriage. 20 to 30% of the times it will run in family. If they are the carriers. The first PFIC or progressive familial intrahepatic cholestasis was known as Byler, one of the scientists in US. PFIC type 2 is what our patient has. They both have low GGT. If you see, our patient has a GGT of 30. This is because of the absence of a gene product which is required by the canals and bile formation. So basically, when there is absence of the gene product, the canals do not export out the bile and the bile just builds up into the system. Patients with PFIC type 3 have deficient hepatocellular phospholipid export and they have a higher GGT. So the differential between PFIC 1, 2, and 3 is basically PFIC 1 and 2 have low GGT. That's how the GGT becomes so important. And type 3 has a higher GGT. Chronic cholestasis disorders that begins in infancy. So basically PFICs will have cholestasis starting like in our patient. It started actually by 7 months. Then 9 months became worse, and then by 11 months had jaundice. So basically, that's the age. Sometimes they can present even earlier, like 3 or 4 months of age. Jaundice average age of onset is 3 months, sometimes later in the childhood. PFIC can progress rapidly and cause cirrhosis during infancy. PFIC 2 constitutes 50% of all the PFICs. So this is PFIC 1, 2, and 3. We don't have much knowledge about 4, 5, and 6. But the important takeaway is here. So if you look at the GGT, it's normal or low, but in 3, it is elevated. The other important thing is, based on the histopath where I said they have giant cell hepatitis, and here they have ductal proliferation. And, there is one more thing which becomes if HCC, your hepatocellular carcinoma, if PFIC2 is not treated earlier, then by the end of first year, you see it here, the risk of HCC is very high. That's the reason we push them for an early transplant, and we keep doing the USGs every 6 months, even after doing a transplant in PFIC type. So what's next? We listed him for a liver transplant. This is already done. The other option is biliary diversion. So you can do a surgery and divert the bile flow, but doesn't help much. I started this child on ursodeoxycholic acid. Before transplant, all like other kids, we have to improvise on the nutrition with vitamin A, D, E, and K, iron, calcium. Put them on a high density protein-rich diet. The better the weight, the better are the transplant outcomes. So we expect a weight of more than 10 kg, of course, but we are not always lucky. We did a transplant on a kid called Zohan, and the weight was only 4.2. He's coming out of the ICU now and he's doing well.
Super.
So you can take this picture if you want. Just click. It may help with the dosing actually of the vitamin A, D, E, and K. Okay. So what happens? What are the complications of all this? So while they're awaiting the liver transplant, while we are waiting for the genetic test, what can happen? So of course they have fat malabsorption because they have low fats. The fat soluble vitamin will be deficient in the form of A, D, E, and K. There's a lot of pruritus, whether it's allergies, whether it's PFIC. They can have hyperlipidemia. They have a growth failure, and of course progression to end-stage liver disease. And definitely these are candidates for the liver transplant. Okay, so that was about it. But I was talking about the other child. So we did a patient that you must have seen. I shared Karthik. Karthik is also PFIC. Now his younger sibling father got, because they were coming from Sangli for this liver day celebration, and he had showed me earlier also. So that girl again has starting, she's getting ecteric. There is a lot of scratching. She's not able to sleep. Basically, she keeps pulling her ear because of the itchiness. Sadly, I got the USG done. The USG again is showing hepatomegaly and parenchymal changes. And I've just asked them to repeat the LFTs. Probably even the other sibling will need a liver transplant. The bad part is Dadi was the donor. So grandmother was the donor because father is an alcoholic, so it did not fit in. And mother was ABO incompatible in the child that we did, Karthik. But now when it's turned for the other sibling, the sister, it's going to be again a more fussier thing. So now let's talk about hereditary hemochromatosis. Excess iron may accumulate or not. Excess iron may accumulate in the liver in autosomal recessive disorder, which is your hereditary hemochromatosis. Any patient with elevated iron or TIBC capacity ferritin values, those with a family history of liver disease or of hemochromatosis should be thought about having hereditary hemochromatosis. How do we diagnose hemochromatosis? There is a mutation in the gene, HFE gene mutation, and a liver biopsy which will indicate that there is definitely a very high serum ferritin level of more than 1000 nanogram per ml or having abnormal liver enzymes. Your hepatic iron concentration, which is your dry weight upon your patient age, again will tell you that when your HH, it's called HII value, which is the hepatic iron capacity. Less than 1.9 is normal, values more than 1.9 are seen in hemochromatosis. Some of these kids, actually, some of these females who are carrying these babies can have frequent, what do you call, miscarriages. And when they say that there have been multiple miscarriages, and when you see a child with jaundice, then always think about hereditary hemochromatosis. Why is the copper test important? So a lot of you were talking about copper or Wilson's. So copper may accumulate to moderate access in the liver in any chronic cholestasis liver disease. So not copper deposits in many chronic conditions. That does not mean they have Wilson's, but Wilson's disease definitely has pathologic copper deposition resulting in serious liver injury, including cirrhosis. In Wilson's, so I was seeing a patient of Dr. Rajesh Udani with a problem in the basal ganglia of the brain. This girl is 14 now, but she started having this wide gamut of neurological abnormalities. In her, she was a very active, sporty child. She's very tall, but now she cannot even read, cannot even write, cannot even have a proper speech. So dysarthria, problem with the speech, it all comes in when the Wilson's, when there is copper in the brain, and when the Wilson involves the brain first. If it is left untreated, the patients will not make it beyond the 40th birthday. So all these kids, whether they are neuro Wilsons or whether they are liver Wilsons, will require a transplant. And this is what I told Dr. Udani, that even if it is neuro Wilsons and her liver enzymes were not very bad, a liver transplant will benefit. Sadly, again, in this family, the father and the mother are both carriers of Wilson's, so they are out as a donor.
But
When
is
your
the
serum
neuroregression reversible?
So that's the thing I told him. It might not be, because we have already lost 4 years. So she was diagnosed in 2017. Had we done it earlier, then definitely. See, the problem, ma'am, here is the liver, because that's where your copper is getting processed. And if you replace that bad liver with a good one, then definitely there won't be any further deposition in the brain, and we could have, stopping the regression would have been much easier. Not that she's not completely bad. She can still walk. She can still communicate. Not like before, but I think offering her a liver transplant, even I don't know, but will be better rather than not doing anything for her.
So are you saying that any child with Wilson's and the onset of neurological disorder, one who needs a liver transplant?
Yeah. So the thing is, Dr. Udani tried everything, all the chelating agents. Actually, with penicillamine, because what happens with penicillamine, it can go bad also. So actually, the symptoms became worse. Presently, she's on zinc, but again, not doing well. So when you have tried it for 1 year and all these medications are not helping, then definitely they are the candidates for a liver transplant, for sure. Can I proceed? Okay. A serum ceruloplasmin level of less than 5. So strongly, this will suggest that there is Wilson's disease, while subnormal level warrants. So if the level is, so basically the serum ceruloplasmin level normal is 20 and above. If you see between 15 and 20, not necessarily it's Wilson's, because if your albumin and total protein is low, even your ceruloplasmin, which is a protein, will be low. But if it is less than 5 milligram, definitely then you are talking about Wilson's only. A serum ceruloplasmin level less than 20, a 24-hour urine copper greater than 40 micrograms, and the presence of KF ring confirms the diagnosis of Wilson's. So this is, out of this, 2 can be done within the same day, and you will know that it is Wilson's. So basically, when we speak about Wilson's, it is basically the problem with chromosome 13. It's a ATP7B gene mutation. So you have all this. You have a KF ring. There is high urine copper with a low ceruloplasmin and very high free copper. Then we call it as wing beating tumors, because tremors, because they have this tremors which is basically to do with the globus pallidus and putamen, and actually it's like a face of panda when you see in the MRI. So this is how we describe Wilson's per se. Now, diagnostic test for Wilson's, of course, the level 1 test is doing a ceruloplasmin, which is quick and easy, getting an ophthal check for a KF ring, doing a free copper level, which is usually elevated in Wilson's, but the main one still remains at 24 hours urine copper. And if it is more than 100 micrograms per 24 hours, then definitely it is Wilson. If you're still, and if there's still some problem with the level 1 test, we can still do a liver histopath. And if your liver copper concentration is more than 250 microgram dry weight of liver, then we are dealing with Wilson's. Third one is definitely it will take longer. It's mutation analysis. Then there will be ultrastructural study of hepatocytes, which is not there in India, and incorporation of radiocopper ceruloplasmin. Now, that was hemochromatosis, neonatal liver disease. The ones that starts actually by 4th, 5th, or 6th birthday is your autoimmune liver disease, and sometimes they are picked up in the 2nd decade of life. The two most common forms of autoimmune liver disease are autoimmune chronic hepatitis and PBC, which is your primary biliary cirrhosis. 90% of those with each disorders, sadly, are women. Autoimmune hepatitis is characterized by very high ALT and AST. If you remember the first few slides, we said elevation, very high elevation of ALT and AST seen in autoimmune hepatitis. PBC, which is more in almost going towards the adult age group, is your PBC, primary biliary cirrhosis, is cholestatic disorder with predominant elevation of ALP. So here the ALP comes into picture. Each of this autoimmune liver disease is associated with autoantibodies in the serum. And again, they are easier done these days. So basically, when you compare the both, this is what I made to make it simpler. Your AST and ALT is 7 to 10 times upper normal limit in autoimmune chronic hepatitis or autoimmune liver disease. In your PBC, it is just mildly elevated 1 to 3 times. Your alkaline phosphatase is very high in PBC that you see here. Then these are some of the autoimmune antibodies. Okay, so the first one is anti-smooth muscle antibody, which is seen in 90% of your autoimmune hepatitis, not much common in PBC. Your AMA, which is your anti-mitochondrial antibody, is mostly seen in PBC. So that's how we differentiate. So one has an anti-smooth muscle antibody, which is your autoimmune liver disease, and the other one, like PBC, has anti-mitochondrial antibody. In the pediatric population, what we see is your LKM, liver kidney microsomal antibody, is positive. Mostly all the kids have this positive in some cases in which smooth muscle antibody is negative. But definitely when this comes positive, it's mostly a pediatric population and it's negative in PBC. Any questions here?
Yeah, Lalit, both primary biliary cirrhosis and autoimmune chronic hepatitis are both autoimmune hepatitis?
Yes. So, yes, ma'am. So one will have anti-smooth muscle antibody positive. And if it is a pediatric population, they will have anti-LKM positive, which is your autoimmune liver disease. The other condition, which is your primary biliary cirrhosis, mostly has AMA, which is your anti-mitochondrial antibody, which is positive. And it usually happens, in age group 18 years and beyond that. Mostly when we see in less than 18 years, it's your autoimmune liver disease, purely anti-smooth muscle antibody positive and anti-LKM positive. The youngest child I know is from Mira Road only. I think we picked up that child at 4.5 years of age. I started this child on steroids, still maintaining fine. But not every time they'll be okay with steroids or even Azoran. Sometimes when this fits, then definitely we should list them for an early transplant. Otherwise, they will go into acute liver failure. So liver, as we, Dr. Girish also opened up, it maintains most of your synthetic function. Of course, albumin is processed here, synthesized here, solely synthesized by liver. It has a half-life of average 25 days. It is an important marker to assess your chronic liver disease because in chronic liver disease, the albumin goes down. Significant reduction is seen in liver disease. Also, it is low in malnutrition. So if it's a malnourished child, it will definitely be low. Cirrhosis of liver causes reversal of albumin globulin ratio. So your globulin increases and albumin decreases. Next one is your prothrombin time. If it is deranged, then we know it's liver. Most of the coagulation factors associated with clotting are processed or synthesized here. Cirrhosis leads to impaired coagulation profile and prolonged PT. Elevated INR of more than 1.2 or 1.5. And if it is more than 2.5, definitely that patients should be referred in the setting of abnormal LFTs in a higher center, because they will just require a liver transplant in the next 3 days if not managed earlier. Elevated INR causes increased risk of bleeding. So apart from liver biopsy, now we have newer modalities. Of course, but the gold standard still remains liver biopsy. Liver biopsy is the gold standard for determining the stage of liver fibrosis and cirrhosis. Most widely studied and promising non-invasive test is elastography, that is common these days, and it's used for serologic marking for us fibrosis. Hepatic elastography is non-invasive. It can be an MRI based or ultrasound based, where it is called as fibroscan when we do it with the help of ultrasound. Few centers in Bombay also have this fibroscan available these days. Basically, it is to do with the waves, and that's how we record the stiffness. And there is a clear value of more than 10, then your liver is definitely fibrotic. But I still say that when we're doing a test, it should add value. Of course, I know now, okay, the liver is fibrotic. So basically, it should be done in NASH. It should be done in alcoholic cirrhosis, where we know, okay, we know the underlying cause. But when we're dealing with the pediatric population, we should not try and get into this fancy stuff, because liver biopsy actually tells us more. Liver biopsy will tell me about whether it's iron, whether it's copper, whether it's biliary atresia or something more. So for me, liver biopsy still remains the most important tool in the assessment of liver fibrosis and cirrhosis, though it may significantly decrease in future with further development and validation of the non-invasive test. But presently, we should opt for a liver biopsy. Final slide. Can you see it, or should I enlarge it? If it's visible, I'll not change it. Let me see if I can. Okay, do it here. Okay. So basically, hepatic causes are also divided in two groups. One is your hepatocellular injury, and the other one is cholestasis, which is your biliary injury. Patients with hepatocellular damage generally have a disproportionate elevation of serum aminotransferase compared with the alkaline phosphatase, while those with cholestasis have opposite pattern. What I mean here is, when there is a pure viral etiology, which is your hepatocellular injury, you'll have a significant elevation in SGOT, SGPT, versus something like choledochal cyst or biliary atresia, where mostly your alphos and GCT will be elevated. Now, when we talk about hepatocellular injury, then definitely a viral hepatitis like HAV, HBV, HCV, D, and E, and other possible viral hepatotropic viruses is what we call them, including your malaria, dengue, CMV, EBV, can all have this rise. Medication, almost any medication can cause an elevation of liver enzymes. The most common drugs, as I said in the earlier slides, are NSAIDs, anti-tubercular drugs, antibiotics. It can be augmentin, azithro, anyone, anticonvulsants, and your Chinese herbal medication. Actually, when I was in Surya, we had a patient who could not be revived because she presented with INR of 8, and the mother was giving herbal medication and just keeping her at home. Even statins can cause liver problem. Alcohol abuse, this is a common finding in adults. In this case, the AST to ALT ratio is more than 2/1. Hepatic steatosis and steatohepatitis is when we call it as NASH. These conditions are common causes of mild, less than 5 times elevation of transaminase. The differentiation between steatosis and steatohepatitis definitely requires a liver biopsy, because steatosis is just accumulation of the fats, but steatohepatitis is actually your liver parenchyma is getting damaged with an inflammation. So definitely we need a liver biopsy for this. Autoimmune hepatitis may present with isolated liver enzyme elevation. Therefore, in any case of unexplained prolonged enzyme elevation, AIH must be considered. A liver biopsy is needed for confirmation and before starting treatment. So there is something called, when you do a liver biopsy in autoimmune hepatitis patient, what we see is there's some term called interface hepatitis, which the pathologist, a good histopathologist, will be able to tell me. So that's how even in AIH, the liver or autoimmune hepatitis, the liver biopsy becomes very important. In Wilson's disease, patient with Wilson disease may present with isolated aminotransferase elevation without any clinical symptoms. So definitely, if you have this patient, initially they might not have tremors, they might not have ascites, but continuous elevation of aminotransferase definitely needs further investigation. In GSD's glycogen storage disease may present with isolated liver enzyme elevation. I just have a patient from Amravati, 9-year-old. But can anybody tell me how does their face look?
How does
Facial features of glycogen storage disease patient. It is
chubby
anyone?
and enigmatic?
Yes, doll-like face is what we call them. So typical doll-like face. Somebody in one of our intensivists at SRCC was asking. I said, "ये GSD है," because it was very typical doll-like, and they're very stunted. They're very stunted growth. Turn out to be GSD type 3. Hemochromatosis is a common genetic disorder usually seen in adults, which may present with isolated liver enzyme elevation, but also in pediatric. Alpha-1 antitrypsin deficiency, of course, is the most common metabolic cause of liver disease in infants and children. It may present with isolated liver enzyme elevation again. But now, so this was the old school thought that alpha-1 antitrypsin is very common. What we are actually seeing is we are seeing a lot of PFICs that were earlier treated like biliary atresia, then they underwent Kasai also many a times. And so we have to make sure that we're picking up the right PFICs and the right biliary atresia patients. Then there are biliary disease. Patients with biliary disease may present with isolated liver enzyme elevation. In those with biliary disease, there is significant elevation of alkaline phosphatase and GGT, which is the best distinguishing factor between hepatobiliary disease from extrahepatic causes. So you got it right?
No.
All these above ones we spoke about were to do with the hepatocellular damage.
Yeah.
The second damage happens is when there is, so we're talking about liver first, just the liver parenchyma, where your Wilson's, your hemochromatosis, your autoimmune hepatitis is a problem, are the diseases. Now, when we talk about particular things like choledochal cyst, extrahepatic biliary atresia, is to do with the bile, the common bile duct and the bile ducts, even intrahepatic. So that's where the GGT and the alkaline phosphatase will be elevated. Clear now?
Yeah.
Sometimes very high levels of ALT and AST more than 15 times are seen in acute viral hepatitis, medication-induced toxicity, toxins that we spoke about, hypoxia or hypoperfusion due to shock. It can be cardiogenic or any other. In cases of liver shock, there is also a significant elevation of LDH. That's where the LDH comes into picture. Aminotransferases are one of the most important means of following patients with acute and chronic hepatitis and the response to medical therapy. So once we do it, we should repeat it. Sometimes with Utcament or UDCA, it can go normal, but we have to make sure that we have to bring them back after 2 weeks or whenever it's required and repeat the LFTs and see. Some of these conditions will have a vaccine waning pattern of the SGOT, SGPT. So definitely we should do a complete enzyme workup in all of them. That was all about it. I'm not presenting hepatitis A or the other viruses. I'll be covering those, Dr. Anjali, as we discussed during the July month. And
Yes.
it will be a presentation on pediatric acute liver failure, which is your PALF, where we include more of conditions that includes viruses and acute liver failure.
Super.
Okay.
Super.
Good.
You covered something we've never spoken about, that is PFIC, Wilson, and autoimmune. So that's awesome, Lalit.
Thank you. Sorry, it just went a bit over, but it's very difficult to cover in 1 hour. So definitely, but yeah. Nowadays, seriously. So yeah.
Yeah, you were saying something.
Nowadays, that's what I said. There's a patient from Virar only, was sent to I can't name the hospital, it's a public forum, to XYZ surgeon for a Kasai procedure. The patient landed up with me, jiski mummy abhi nahi bachi after that iron injection. I said, I don't, of course, the SGOT, SGPTs were in 200, 300. It was very jaundiced. Admitted at SRCC. I said, I don't really think it is biliary atresia. So I did another fasting, USG, a good fasting, 6 hours fasting. Parents were upset, but I said, that's the only way I will know. Then we also did the MRCP and the gallbladder was nice and clear. So we said, okay, biliary atresia is out. I said, now we have a lot of time. I can just make your child stable. Then I think I was going to present it, but I can present. I can tell you now. Then we sent the whole exome and turned out to be autoimmune thyroid. So does not require a liver transplant. Rajesh is following this child as well. I've involved Dr. Rajesh Joshi. And the liver transplant is out. Had the Kasai, if the Kasai was done, we would have just landed up with a transplant, because we know once your Kasai is done, after whether 1 year, 2 years, the child will be taken up for a transplant. So I'm happy because the liver looked normal, and I said it's not ecogenic, so it's not biliary atresia. The parenchyma was still normal, and that's how we are able to save this child. But I'll be presenting another 3 kids which did not require liver transplant. वो लोग मुझे बोलते हैं कि तुम सिर्फ liver transplant की बात करते हो, but I have to present these stories where actually we did not have to do a liver transplant with a multidisciplinary team approach and proper thinking.
Yeah. So, but why was this child with autoimmune thyroiditis jaundiced? So
you're right. So even so basically we know that hypothyroid or pan hypopituitarism can cause liver problem. Of course, hypothyroid we must have picked so many and we have treated them. But hyperthyroid is rare. So I'm just thinking whether this child might have in future autoimmune hepatitis as well. But right now the liver enzymes have settled down. CMV is borderline elevated. So I've started him on treatment of Palghar. The liver enzymes are normal, completely normal. The weight gain is there. So I said we'll wait for some time and then reevaluate every 3 to 6 months.
We had a child recently who was 11 months and, like you said, had a baby doll face, completely edema. Blood sugar was low and was convulsing continuously. So we did a lumbar puncture. Even the lumbar puncture showed very, very low, 7 milligrams of sugar. And this child had a huge weight. But parents could not afford, and we had to transfer to KEM. So I'm suspecting this child could have had a glycogen storage disorder.
Yeah.
And a huge liver, and that was the reason that the sugars were low.
If anybody is not affording now, please let me know, because we have funds for, because it's a new annual year. So we are doing one of the patients for almost no cost. We can do 4 or 5 in a year with this. I just had a discussion after that liver meeting. The purpose of the liver meeting was to sensitize a lot of us. And of course, I talk about our IIP Palghar group also, where I said that we do a lot of academics, and I'm sure a lot of people got excited. And everybody's excited. And there is a neurosurgeon who also wants to present. So I think, I've told them at least 4 to 5 patients, because we can generate funds with the crowdfunding platform. It's never a difficult thing. We can get some of the tests done outside to save the cost. Never a problem.
Super, super. So, Lalit, I'll find out what's happened to that child.
Sure. Thank you very much. Thank you for being here.
Girish.
Thank you. Thank you, everyone. Thank you, Dr. Lalit, for really a very nice and comprehensive presentation of different liver disorders. And as Madam has already, Anjali Madam has already said that PFEC and autoimmune thing is a new sensitizer for us. And thank you on the behalf of IIP Palghar Group, and thank you everyone.
Lalit, you said about we measure in a cirrhotic patient which are non-alcoholic, elastic. Some of them are doing camps also. So how is ethical that to doing camps for such?
Camps for, sorry?
Fibroscan.
Fibroscan.
For the alcoholics?
Yeah, or not alcoholic, general public people, like many gastroenterologists, hepatologists are saying that we will do this on a camp basis. We'll bring the machine and also.
Yeah.
You may label someone on just one scan that he has got some liver disease. So,
exactly my problem with the fibroscan. I think it is overrated. We should only do it when we actually have diagnosed a condition to, like a response to therapy kind of thing. I don't think that should be the primary means to diagnose a condition, especially a liver, because some of this will just end up saying, okay, the liver is fine, kuch zarurat nahi hai, hamara doctor ne ye bola fibroscan. But it's very, it's basically depends on who's doing it, the experience, and so on. So I don't think you're right. I don't think we should do a fibroscan at all.
Lalit, some of these PFEC cases, were they diagnosed as neonatal hepatitis earlier?
Yeah, you're right. Neonatal hepatitis, some of them as biliary atresia, taken up for the Kasai and further like whatnot. So I'm just, because, I was going through a lot of, one of the setup, and, I figured out at least 3 that were not biliary atresia. That definitely would not biliary atresia. So what happens, like this child, of course, he's lost the mom. I said, lucky that the father is now having a child who's normal at least, and not having undergone a Kasai and not have to undergo a liver transplant, hopefully in future. So Dr. Vaibhav will remember. I think Jagravi को मैंने बोला था कि उसको follow up करते रहो. ठीक है.
Good.
Lovely, Lalit.
Thank you very much.
Okay.
Yeah, so many new terms and so many new conditions that now we'll have to look at. So many conditions where the liver enzymes are elevated, and we only knew of, viral hepatitis. So many new things you have.
Yeah, easily, of course, we should do viral hepatitis. I think a patient from Basri only who presented very sick when I joined in, me and Samir were here, and just turn around, because I thought, my God, INR of 5, 6, staying in for 5 days, we didn't have transplant, then what do we do next? But turn around. But yes, I think that should be the another topic in July. But I really want to do whom not to transplant. So there are at least 3 conditions. One of them managed by me and Anita Hegde. So definitely we should bring that in. I'll ask her if she wants to join for that patient.
Super.
Thank you.
So we never have a dearth of topics to discuss, Vaibhavi.
Yeah, Palghar group mein nahi hai.
Oh, so much to discuss and so much to learn. So much to learn. Yeah.
Yeah. Thank you so much.
So thank you, Lalit.
Thank you.
Thank you, madam. Thank you, madam.
Thank you, Girish. You've done a fantastic job, and your introduction was very nice. Thank you.
Okay,
Thank you,
thank you,
Dr.
madam.
Girish.
Thank you.
Everyone.
Thank you all. I'll see you around then.
Yeah.
Bye-bye.
See you
Okay,
Lalit. Bye.
I'm closing recording.
Yes.
Yeah.
Thank you.